This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended.
Hi, this is Dr. Deepak Megur, and in this video we're going to analyze how do we set the power in a particular case. In my many past videos I mentioned that the only parameter which I usually tweak is the power, and it's going to vary on case-to-case basis. And this is one example where I just want to highlight this usage, and she's a 38-year-old young lady who has this presenile mature intumescent cataract. The reason I tell age in every case which I present is that the age has some importance. The younger eyes behave slightly different in the way an elderly patient or a middle-aged patient would behave. In this young patient, the capsule is going to be very elastic, and in the presence of an intumescent lens, there is some chance of the rexus going uncontrolled and extending out. The second consideration would be the nucleus would be extremely soft in this age group. Of course, it will not be as soft as in a 20-year-old person, but still it would be relatively softer, and this is where we are going to use appropriate power modulations to help us emulsify this lens in an easy manner. The side ports are made, the capsule is stained, the eye is pressurized with dispersive OVD, the main incision is created. Time to perform the rexus. I'm using a forceps to puncture the anterocapsule. The flap is raised and I begin to tear the capsule. My goal is to perform around 4.5 millimeter rexus, not more than that. So as a rule, when we're dealing with younger patients, we want to aim for a slightly smaller rexus because eventually it turns out to be slightly larger than what we had planned owing to the elasticity of the capsule. In this case, there's another reason for us to aim for a smaller rexus is that the presence of an underlying intumescent cataract. So in this case, the rexus was perfectly fine without the need of doing a two-stage rexus, no need to aspirate the cortex. Well, this has been my go-to technique of late. I've stopped doing the two-stage rexus in majority of the intumescent lenses. I realized the secret to achieve a predictable rexus every time is to have a soft eye. So either you can use some form of local anesthesia and give a massage which will make the eye soft. In extremely shallow antechambers, maybe an IV mannitol along with the massage dose helps to make the eye soft. In a soft eye, the rexus becomes extremely well controlled and it is predictable. The most important step in the surgery is already done, this rexus. In these younger patients, nucleus management is going to be relatively easy. Now, coming to the main point of this video, like how are we going to set the power? See, obviously the epinucleus is aspirated out, and now is the time to do the nucleus management. So, as is customary, the power is set at longitudinal for my chopping mode, and the power which I am selecting is just 5%. This is the lowest possible power available in this machine. So, we kept the power at 5%. Just to give you a comparative idea, for an average grade cataract, I would keep the power anywhere between 25 to 30%. Now this is a very soft cataract. I kept the minimum, that is 5%, and that should suffice. The first step always is to engage and bury my phaco tip into the nucleus so that I can hold it well to chop. So in these softer nucleus, we don't have to have a very deep burying of the phaco tip. Even a small engagement of the nucleus is good enough to go and chop it, and that's what I'm doing. So you can see just hardly maybe 10% of the tip is gone into the core of the nucleus. The chopper goes down vertically and then we have a crack. Just hold it and then chop. The same process is repeated. And just to demonstrate what would happen if the power is increased, for second heminucleus, I've just increased the power to 10%, and you can see suddenly that this 10% was too much. Suddenly the nucleus just sprung away and we could see a deep trench. So remember, in softer cataracts, especially in younger patients, start with the lowest possible power, especially when you're trying to hold the nucleus to chop. So if you're going to use more power, you're going to create a hole, and there is no vacuum, and in fact there's always a risk of creating a hole through and through and a risk of causing a PC tear. So dial down your phaco power in such eyes. So once the fragments are created, now is the time to emulsify each of these fragments, and the setting here would be only torsional energy in a pulse mode, and the power which I kept is 30%, and it's a very easy job to do it. The fragments are all aspirated in a jiffy, and now we need to clean the bag. So you can see in these mature cataracts, these individual small fibers will be sticking onto the posterior capsule. It could be tricky to just go and aspirate them. The best way to deal with them is to first loosen them by irrigating BSS onto the posterior capsule. It just loosens it. And then we're going to go ahead with the bimanual I&A and aspirate the cortex. Now the bag seems to be clean. Time to implant the planned lens. So we planned a multi-piece lens in this patient. The bag is inflated with OVD. The distal haptic is negotiated into the bag. The proximal haptic is then gently dialed in. OVD both in front of the lens and behind the lens is irrigated out. So let me just explain how do we manage OVD removal. A quick and easy way to remove the OVD is to go with only the irrigation probe through the main incision. I'm just going to lift up the lens. The irrigation handpiece slides under the lens and the irrigating fluid itself washes off all the OVD which is sticking onto the back surface of the lens and within the bag. And by compressing the floor of the main incision, there's a passive irrigation of fluid out, and that's the reason why we have a quick removal of all the OVD. The OVD is just washed off. Then the cannula comes out in front of the lens, and then the OVD in front of the lens and in the antechamber is irrigated out. The ports are directed towards the cornea to remove all the OVD which is sticking onto the cornea. It just takes a minute or two, and it's a very quick way to remove all the OVD from within the bag and as well as from the antechamber. Just irrigation. The ports are hydrated, that's it, the case is done. So to conclude, this short video highlighted the way we can utilize the change in the power modulations depending upon the density of the nucleus. In this young patient, we expected a very soft nucleus, and we used the lowest power which is available in the machine to do the chopping maneuvers. So that was it. Thank you for watching, and hope you found this helpful.